Hello everyone. So I know this topic is very boring topic, so let's try to make it a little bit interesting. Let's go into metabolic response to injury. What is the metabolic response to injury? So whenever there is any injury or any surgery or any trauma, it will cause local tissue inflammation. So this local inflammation, it might go into systemic and cause systemic changes affecting the organ function. There is something called surgical stress response. That is, whenever there is surgery, stress is responded in the form of three categories. First one is hormones, second one is inflammation, third one is neural circuits. So all these will lead to alterations in the body metabolism, wound healing, immunity, as well as specific organ functions. So in metabolic response to injury, it is mainly briefed into two phases. Initial phase of catabolism followed by later phase of anabolism. So initially it may or may not include the phase of shock. What do you mean by catabolism? So whenever there is any kind of breakdown, it is known as catabolism. So what does a body do? Body will try to retain everything, retain the volume, retain the energy stores. So here it will try to conserve the volume, leading to hypovolemia. When there is decreased volume in the blood, so heart will have decreased input, leading to decreased cardiac output and decrease in basal metabolic rate, temperature, as well as lactic acidosis. The metabolic response to injury is always graded in nature. What do you mean by graded? So that is proportional to each other. Whenever there is if there is a graphical representation, if it is a minor injury, it will cause minor metabolic response to injury. If it is a major trauma, it will result in the increase in the BMR and nitrogen balance correspondingly. It always varies with time and also depends on the genetic individuals. Next, what I have told in the form of hormones, inflammatory response, and neural circuits. So let's dive into inflammatory response. There is something called Matzinger danger hypothesis. So remember the name. It just represents how the inflammation is going on in our body. He proposed a hypothesis. Whenever there is any tissue or in tissue injury or any trauma, what does it cause the cell? It causes cellular lysis. This cellular lysis will cause release of some proteins. What are they? They are known as DAMs. These proteins are due to damage. So remember it like damage associated molecular proteins. It might be due to some pathogen also. They are known as PAMs, that is nothing but pathogen associated molecular proteins. These DAMs will get released into the blood circulation. They will be picked up by our antigen presenting cells, that is macrophages, dendritic cells, neutrophils, which have receptors over them. They are nothing but pattern recognition receptors. Examples include toll like receptors, nod like receptors. All these will catch up the DAMs which are circulating in the blood and they'll engulf into them, leading to the caspase activation and formation of an inflammasome. This caspase will lead to starting of inflammatory cascade, thereby leading to release of interleukin 1, interleukin 6. These two are very very important. There are many inflammatory cytokines, but these two are important, so kindly remember these two, interleukin 1 and interleukin 6 will cause local inflammation. If it becomes systemic and uncontrolled, it will cause systemic inflammatory response syndrome, ARDS, and multi-organ dysfunction syndrome. These three are very much important DAMs. There are the DAMs which are released are named. There are many DAMs, but there is something called high molecular globulin protein B1, that is most commonly released damage associated molecular protein whenever there is any injury. There is something called heat shock protein 70, that is second most commonly released after HMGB1. S100 is a specific damp released in case of traumatic brain injury. So this inflammatory process is conducted in first 24 hours, after 24 hours, and further changes. In first 24 hours, there will be pro-inflammatory phase. This is the graphical representation of how it is showing. So pro-inflammatory phase will be conducted within the first 24 hours, leading to release of, as I have told, interleukin 1, interleukin 6, and TNF alpha. They will be released into the circulation, as well as nitric oxide, prostanoids, and endothelin 1. These three will cause vasodilation, leading to leaky capillaries. As our favorite albumin has so much transcapillary escape rate, it will escape. So in case of sepsis or in case of shock, albumin will be in less quantity. So it is known as negative acute phase reactant. And after 24 hours, to balance this inflammation, there is something called endogenous cytokine antagonist. If you are struggling to remember endogenous, what does endogenous mean? Within the body. So within the body, to fight this cytokine, body is releasing. So endogenous cytokine antagonist, they are released after 24 hours, and as well as lipoxins, resolvins, and protectins, these are released. Further changes, so body will try to maintain a balanced state. Ultimately, there is something called homeostasis. Body tries to maintain homeostasis. So adaptive changes will occur in the form of CARS. What is CARS? Not your car. It is compensated anti-inflammatory response syndrome, leading to release of interleukin 4, 5, 9, and 10, TGF beta. So whenever immunity is suppressed, so we are fighting against the immunity, it will cause immunosuppression as well as infection. So all the pro-inflammatory phase is mediated by the innate immunity, and anti-inflammatory phase is mediated by the adaptive immunity. If this is a point of injury, this is a point of homeostasis. So this is the graphical representation. If the point is not reaching, homeostatic point is not reaching, it will cause, and patient is still in pro-inflammatory phase, that will cause persistent inflammation, prolonged persistent inflammation. And if it didn't reach the end point and patient is still in anti-inflammatory phase, this will cause progressive immunosuppression. See, as I have mentioned earlier, CARS, this is not your car. CARS is compensated. So body is trying to compensate the inflammation. So compensated anti-inflammatory response syndrome. There is something called PICS. What is PICS? As I have told, this is the persistent inflammation which is carrying forward after the CARS also. It is known as PICS, persistent inflammation immunosuppression catabolic syndrome. So if you don't know anything about the metabolic response to injury, you can just simply remember it by this diagram. It is a beautiful diagram mentioned in our Bailey. So this is neuroendocrine response. So if you just draw this table in your exam and if you come, they'll think that at least you know something. So metabolic response to injury. So whenever there is injury, how does a body react to an injury? So it will take up by the efferent nociceptive receptors. These receptors will take into the spinal cord, and from there they will travel into the brain, thalamus, hypothalamus, and pituitary regions. This pituitary, what does it do? General function of pituitary is releasing hormones. So what does this release? This pain or injury will cause the release of ACTH and growth hormone, adrenocorticotropic hormone, as well as growth hormone. Adrenocortico, so it has in its name adreno. It stimulates the adrenal gland. This adrenal gland, it releases the adrenocortico, adrenaline as well as cortisol, and this will stimulate the pancreas, leading to increase in the glucagon. Okay, this is the endocrine pathway. Let's go into this is the neuroendocrine pathway. Let's go into the immunity pathway. So this will cause activation of the injury will cause activation of the innate immunity system. As we have discussed, pro-inflammatory phase is mediated by the innate immune system, and later on it will be converted into anti-inflammatory response syndrome by the adaptive immune system. These are the cytokines which play a role: interleukin 1, interleukin 6, interleukin 8 and TNF alpha. These are the very very important cytokines you must remember. These are the cytokines responsible for pyrexia in a patient, that is fever in a patient. So there is all these hormones will cause changes in the body metabolism in the form of this adrenocorticotropic hormone and growth hormone increases, ultimately leading to increase in glucose, that is lipolysis will be more, and adrenaline and cortisol will cause hepatic gluconeogenesis. In glucagon, it causes skeletal muscle protein degradation, and hepatic acute phase reactant protein synthesis will be more. In case of, as it is a state of hypermetabolism, there will be a decrease in basal metabolic rate is maintained by thyroid hormone. So when there is hypermetabolism, thyroid will go down, so thyroid hormones will be low, testosterone will be low, insulin will be low. So, and one more thing is neural circuits. When there is any injury, the sympathetic nervous system will get activated, leading to causes in adrenal and pancreas stimulation, thereby release of these hormones. So this is the entire image can just simply tell your neuroendocrine as well as inflammatory process of metabolic response to injury. This is very very important, kindly remember it. So this is how this is just a diagrammatic representation of how does a body react to injury. So within hours it will cause shock, conserves the circulating volume as well as energy source. Within days it causes metabolism, so catabolism, that is mobilization of the energy sources. Later on, by the end of the weeks, it will convert into anabolism, leading to tissue repair. This is again another image showing how a peripheral tissue is transversed, energy sources are mobilized into the central tissues. As we have discussed earlier in the image, so there will be degradation of proteins in the muscles, adipose tissue as well as skin, leading to amino acids formation, and then they will mobilize into the central vital organs like liver, immune system and wound. How do we cope up with metabolic response to injury? So what should we do? There is so much going on in our body. So what are we supposed to do? There is something called stress-free perioperative care. We'll try to decrease the stress near the perioperative time. How? These are the secondary triggers of metabolic response to injury. That is sepsis, hemorrhage, massive transfusion, acidosis, surgery, crush syndrome and ischemia reperfusion syndrome. All these are one of the trigger for metabolic response to injury. So we try to avoid them or we try to correct them. So we try to decrease them and limit the crystalloids with no weight gain during elective surgery. In elective surgery, as we keep the patient nil per oral for more than 8 hours, we shouldn't load the patient with crystalloids. We have to limit it to a certain level because surgery is a form of stress, and when you are keeping the patient nil per oral, it is also a form of stress. In stress, ADH will be high, leading to antidiuretic hormone will be high, leading to sodium and water retention, causing ultimately oliguria. And we should always try to maintain 3 normals: normal temperature, normal sugars, normal volume. Normothermia. What will happen if we don't maintain normothermia? It will cause decrease in wound healing, cardiovascular complications. If we don't maintain normoglycemia, there will be increase in the endothelial damage, leading to edema, tissue edema. If we don't maintain normal volume, there will be weight gain, there will be ileus due to edema, and This is a recently introduced term. So when we keep NBM to the patient for more than 8 hours, patient will be in the form of stress, and it will also increase the post-operative insulin resistance. So we have to give a carbohydrate drink 2 hours prior to surgery. So this will also decrease the perioperative anxiety as well as insulin resistance postoperatively. This is newly introduced one. So we should always avoid unnecessary bed rest and early mobilization. In over the muscle there will be something called GLUT4 receptors, that is glucose transporter 4 receptors. It when the patient is in resting phase, these receptors will not be produced. So when patient mobilizes, so patient on the muscle there will be a formation of this GLUT4 receptors, leading to uptake of the glucose, thereby decreasing the insulin resistance and hyperglycemia. So there is ERAS approach. What is ERAS? It is early recovery, enhanced recovery after surgery. Enhanced recovery after surgery. This is ERAS. So what does it do? It will try to decrease this metabolic response to injury in the form of, so as the body will respond to more graded in nature, so more the tissue injury, more the metabolic response to injury. So we try to decrease the tissue injury in the form of minimal access technique rather than open techniques. And there will be a blockade of afferent painful stimuli in the form of epidurals or proper analgesics we have to give. Minimal periods of starvation as we have discussed earlier, and early mobilization. I hope this video is helpful to you all. So even if you get a 10 marks long answer question in your exam, if you write this much matter, it will be more than enough for any UG or any PG students. So if you like this video, kindly like, share and subscribe. Thank you.